So hopefully this is not going to be the floor of your OR. There really are, it's a two-prong approach trying to improve outcomes when I think of it with knee surgery. One is you want to try and minimize blood loss, and there are clearly reasons why that would be beneficial. We know that total knee surgery, which is probably the most invasive type of knee surgery we do, can lead to about 1 liter up to 2 liters in some cases of blood loss. So that's a lot of blood loss. Anemia has consequences. Typically these patients, if they've lost a lot of blood, will be slower to recover and mobilize. Certainly the therapists in the room, I'm sure, see that. Increased length of stay, which obviously is a hot topic right now. We want to try and minimize length of stay. Higher post-op infections and medical complications. And it wasn't too long ago where we were transfusing up to 90% of patients after total knee replacement. Now it's pretty much done a 180. And we'll go over reasons why. And then the second prong is managing pain, and we've already gone over some of that. I'll go over into more specific details for knee surgery, but clearly the patients that are having a lot of pain typically report a lot more nausea and vomiting. They don't want to get up with physical therapy. They're slower to get discharged. Their rehab in general just typically doesn't go as well. And I find, especially with my arthroplasty or knee replacement patients, the people who start off slow, unfortunately, tend to be chasing their tails for some time after. It's really important, and I really try and emphasize this with my patients, it's really important to gain some traction in the beginning. If you demonstrate to yourself the first day, for instance, you have surgery at 8 a.m., I try and get you up by 3 p.m. We have great therapists here who get the patients up. The patient automatically it registers with him, wow, I just had a knee replacement and I'm walking on it. The next time they get up, they're walking around the nurse's station. By the next day, they're ready to go home. And so it's all about getting that traction early on. So let's just go over blood loss management. Really, the game changer was this medication. And it's been around forever, and we really weren't using it. It's Transexamic Acid, or TXA, TEA, works by breaking down clots. I'm not going to go over the mechanism, but as I'm sure many of you know, the human body at any point is making clot and breaking down clot. Now, in the immediate perioperative period, you want to try and limit some of the clot breakdown, at least in the intraoperative site, because that's going to limit the blood loss. And this medication does a great job. It can limit blood loss by 30 to 50%. I mean, it really is a complete game changer. We use it in a variety of ways. I give it IV now. The two main things are that it's really, really safe, it's very effective, it doesn't increase the risk of clots, which is something we were really worried about. In orthopedics, obviously, we're getting ultrasounds all the time and worried about blood clots, but in this case, this medication doesn't seem to do that. And from a financial aspect, it's a huge boon. I mean, it's so cheap. It's unbelievable. And when we compare it to other methods that we've used to try and manage blood loss, it's exponentially cheaper. A transfusion alone costs about $1,000. If you did, say, even if you gave the patient their own blood back, that's a very expensive process. If you use Cell Saver, that's a very expensive process. This thing can be $50 or less, and it changes everything. Now, the other thing is very simplistic. It's sort of like one of those, why didn't we do it earlier? But we used to just automatically transfuse. You have a hemoglobin of 10, hematocrit of 30, boom, you'll get a transfusion. So that's why we were transfusing so many partial or total knee patients, or even spine patients, or whatever it was. It wasn't just the orthopedist, it was all the doctors. We sort of had this hair trigger type response where we see the numbers go down a little bit, just give them a blood transfusion. And now we definitely know that people don't need transfusions as often. I really only consider it now if the hemoglobin's below 8, and sometimes it can drift down to 7, as long as they're not having symptoms. I mean, if the patient is getting up with the therapist and their hemoglobin is relatively steady, the absolute number isn't as critical. And that really saves not just the the process of transfusing them, but it also from the financial standpoint, it really helps the overall experience. Finally, tourniquets are controversial among surgeons. I sometimes use them, I sometimes don't. It depends on the procedure. Clearly, they limit blood loss during surgery. I mean, that's what they're supposed to do. But there probably is a rebound effect where you have a little bit more post-op blood loss. But it is just something I mention because I do find that with reasonable tourniquet use and then with hemostasis afterwards, where we try and coagulate any of the blood vessels once we release the tourniquet, I find that blood loss is pretty minimal. So just to give you an example, nowadays, over the last couple of years, I probably can count on one hand how many people I've transfused after knee replacement, even bilateral knee replacement. People have had both knees done at the same time. Now, there are, of course, other factors. Typically, bilateral patients tend to be younger, healthier, but still, just using these methods, that medication, the Transexamic Acid, really has changed a lot of things. And then moving on to pain management, but specifically peripheral nerve blocks. We use this fancy term, multimodal approach, which Dr. Kowalski already touched upon, so I won't belabor it. But it really just means attacking pain from different angles. And so we're going to use oral medications, we're going to use IV medications. I really think using Decadron, 10 milligrams of Decadron at the time of surgery really helps to minimize nausea. Toradol also, I find, which is the medication maybe you heard years ago with the NFL players because they were using it, popping it like candy because it works. It's a great analgesic. The oral narcotics, which we use, again, less frequently. I tell my knee replacement patients, for instance, or partial knees, you'll probably use oral narcotics now for about a week, maybe 2 weeks at most. And even then, it's usually just at night or before therapy. I mean, we're so much better now with the pain management. It's really unbelievable. And my ACL patients, a lot of them rarely use narcotics, more than 1 or 2 days, if that. So a lot of this is because of the choices we're making now. Okay, so peripheral nerve blocks of the knee, just to go quickly over the anatomy. Femoral nerve supplies most of the front of the thigh, the lateral femoral cutaneous nerve on the lateral side, the obturator on the medial side. There's a nerve called the saphenous nerve, which curves around the medial aspect of the knee, which we're going to touch upon also. The femoral nerve block was really the workhorse of peripheral nerve blocks in knee surgery for many, many years. And the reason is because it really works well. It does, we use an ultrasound, the anesthesiologist, and again, I'm not saying this to be patronizing, I don't know if they're in the room, but honestly, our anesthesiology staff here is unbelievable because they really do a lot of these peripheral nerve blocks with such high accuracy. It's really a huge boon for the surgeon. Not every anesthesiologist does that, just so you guys know. So it works great because it really gives a lot of good pain control, but the downside is you also numb the nerves that supply the quadriceps muscle. So it was not uncommon, the rate is probably, I think I've seen up to 10 or 15% where post-op people would have falls. So that's why a lot of the patients in the hospital, you might see them with the knee immobilizer when they're trying to get around with the physical therapist. The other big issue that we had, or at least I had, and I know some other knee surgeons, is the prolonged quadriceps weakness. So we would see this with ACL patients, but also we see it in the total knee patients. The quadriceps would take 6 to 12 months, if not longer, to completely recover. So I've sort of moved away from femoral nerve blocks, and now we do what are called adductor canal or saphenous nerve blocks. And this is an axial view. So this is, say, if you were to put the thigh in cross section, this is the medial side and this is the lateral side. And there's a group of vessels here, including the saphenous nerve, the femoral artery and vein, which are coursing down there that the anesthesiologist can find with the ultrasound and then numb that nerve specifically. And it's just a sensory block. There's no motor component to it. Now, if you were to outline what the two blocks do in terms of sensory blockade, the femoral nerve definitely gives you much more complete blockage of the nerves. As you can see here, the saphenous nerve, or the adductor canal block, blocks the front of the knee and the medial aspect of the leg. So it's not as complete, but it can still give people relatively good relief. And using some of the other things I'll touch upon in the next two slides, we can get a more 360-degree type of pain management control. Over the last year or two, our anesthesiologists are also experimenting with what are called IPACK blocks. And IPACK stands for this interspace between the popliteal artery. So again, this is a cross section. Put the thigh in the deli slicer and you get the femur here. This is posterior, this is anterior. The arteries are right here. This is the lower part of the thigh. So you want to try and carefully get that needle between the vein and the artery and the back of the knee. And our anesthesiologists can do that. They'll inject that area, and we find that that will provide pain management to the back of the knee. And then the last thing we sort of touched upon, Exparel is one of the medications we can use, but you can use any medication. You can use a long-acting anesthetic. You can combine it with Tourniquet, epinephrine, and morphine. But basically, we want to try and inject the soft tissues in the back of the knee. When you're doing open knee surgery, if you can get the, we use a very, or at least I use a very long spinal type needle. I'll just inject, say, 50, 100 little tiny injections in the back of the capsule, and that also can provide great pain relief. So using all of these approaches has really revolutionized knee surgery. It's not perfect. We're continuing to evolve, but I find that things are a lot better for patients, and we can't also discount expectations. So if we explain to patients that this is what you can expect, and this is what will work if we take this approach, I find they're all game, they're all on board. We can discharge them sooner. Nowadays, I'm sending partial knees and even total knees. We're going to send them home the same day. And the only way you can do that is by doing all of these things, as well as getting all of us on the same page and explaining that carefully to patients. So, thank you.